Well, good morning, everyone. First of all, thank you for inviting me to present our journey in terms of becoming a digital exemplar. So I will start by giving you a little bit of an overview on Portugal, where we are today and where we stand, given that we're all coming, as you might imagine, from a 2012 crisis. So Portugal is recovering slowly but steady, and our unemployment naturally is coming down as expected. By some of the key features in terms of healthcare has to do with the percentage of GDP that we spend in healthcare, which is basically stable in the past few years, around 9%. And we have public spending in healthcare about 10.2 billion, which has grown from last year about 5%. The important figure here is the amount of debt. It already accounts for a third of total spending. So there has been under budgeting for healthcare, which means basically that we are growing again a public debt in terms of healthcare. This year, 2019, is a specific, very tricky year because there will be elections there will be elections in October. So we have had a lot of strikes within the recent months. Basically, most of them in nursing. This is a very complicated slide. I wouldn't go about the whole system and how it finances itself, but I would just say that it's very similar to yours, to the NHS in England. And I would point out that the major differences here have to do with the primary care, where it's owned and managed by the government, so it's government owned. So all the GPs are standing in one single location by geography, and they serve the population from that specific organization. Then there are co-payments in the ER. So unlike here, people that use the ER, they have a co-pay in the usage of the ER. Naturally, that there are exceptions to these co-pays, but there is normally a co-pay. And finally, something which is, I would say, a little bit strange, but we've learned to live with it, it's public subsystems. So public servants have access to subsystems, and those subsystems allow them to go to the private sector. So again, it's not really clear, and I think it's a little bit different from what we have here. The total spending in healthcare in Portugal is around 16 billion, where 65% of them comes from direct taxation or from the government. How does the private and the public sector articulate in Portugal? Well, the private basically grants access. So basically there's a lot of outpatient visits within the private sector. As you can see, the total amount of hospitals already exceeds the total amount of public hospitals. The total amount of private exceeds the total amount of public. But when you look at beds at more acute care, there is still more than double the size of public hospital versus private hospitals. So it's basically grants access and reduces, it's basically the length of time between receiving an outpatient consultation. That's where the private sector basically acts. So Lusíadas, we're a private group that basically delivers healthcare. We have 6 hospitals. I would point out here in the middle of Portugal, you have Cascais. Cascais is on the outskirts of Lisbon, and that's the case study that we are presenting today. It's a public hospital within the NHS. So we manage a public hospital in equal situations as the other ones in the NHS. So the NHS, in terms of hospital model, basically all of the hospitals are public. They're managed by, they have a public management. But then there are 4 examples of public-private partnerships. Unlike here, where normally public-private partnerships are mainly PFIs, they construct and manage the infrastructure. What we do in Portugal is we manage the clinical delivery. So we manage public servants, doctors, nurses, and we deliver care to the patients that come to the hospital. In the government's perspective, this model, and I would not speak exactly about being private or public, It's not exactly the point, but the important thing or the important fact here has to do with what was sought when they started this model, was basically to create some accountability from the operator of the hospital. So basically they wanted to improve access, they wanted to have a quality assessment that would be mandatory for these kind of hospitals, and then they would have to have a lower comparable cost when you compare it to the public comparable cost, and have all the risk of the operation transferred to this party. When we managed the hospital, when we started to manage the PPP, we understood that there was a huge alignment between what was stated in Article 64 of our Constitution and our mission. So it was an easy fit, if you want, between what we intend to do overall and what the Constitution states that the government should do, which is to deliver care basically in a universal way and mostly free of charge to everyone through a health system. Not narrowing down one bit more to our hospital, the Hospital de Cascais is a public-private partnership, as I mentioned, that serves a population of around 300,000 people and has some revenue around 80 million euros. It's a general hospital with all general specialties and with all the emergency rooms that that exist. So basically we have a general emergency room, we have pediatric emergency room, and we have OBGYN emergency room, so all three emergencies. And when I mentioned earlier about the importance of the model, not exactly the public or the private, but the model itself, has to do with this. So when you have a lot of KPIs, a lot of indicators, what you obtain is an alignment between the operator of the hospital and what the system seeks. So basically, when you put this kind of evaluation process that can lead to performance failures and therefore to deductions from your payment, what you find is that the operator itself is going to search for better ways to perform and to achieve what is being asked, so his KPIs. And that's what happened in Cascais. So what we're going to show you afterwards, after this slide, is the way we went about to deliver these 83 key performance indicators and how to achieve patient satisfaction at its most. So we believe it's important to show a little bit of our journey in quality, because quality and sustainability go hand in hand. We cannot see sustainability over a long period if it does not keep on increasing the quality of its service. So as you can see over there, we have been accredited by John Commission since 2012. We've started our digital maturity journey, if you want, by a first stage 6 audit in 2016, and then by 2017 we were able to reach stage 7. Of course, all of this has to do with quality and with patient safety. So when we started to manage the hospital, we had to frame the work that we were going to do within one framework. There are lots of frameworks, some more accepted generally than others. We went after IHI, the Institute for Healthcare Improvements, triple aim for healthcare, and there is a +1, of course, and we speak about quadruple aim, although it's not written. We understood that there is a fourth element to achieving this triple aim, which is basically the quality of your human capital and the people that work and deliver care. So basically, the following slides will be how did we deliver that mission, that helping the health system work better for everyone. So basically, the clinical excellence, which is the first corner of the triangle for the triple aim, we believe we achieved the clinical excellence by means of 3 pillars. So the first will be quality and patient safety. The second one would be through technology and innovation. And the third would be by benchmarkers against all best practices and the best performance within the healthcare environment. So naturally, in quality and patient safety, we speak about best practices that are written. So for clinical decisions. We have protocols that are worldwide and that are applicable in every geography. We apply those. We follow JCI standards, and we follow ISOs, both quality and environmental certifications, to making sure that we deliver the best quality of care. In terms of technology and innovation, I don't know if everyone is familiar about what is the HIMSS and the EMRAM. The EMRAM means Electronic Medical Records Adoption Model, which is basically a maturity model that evaluates the quality of the information systems that exist within a hospital. It's a scale from 0 to 7, and in Europe there are 3 stage 7 hospitals. 2 of them are in Holland, and the other one is Cascais in Portugal. It means that we've reached a point where the scale believes that we are digital mature. But it's not an end result, it's a journey, and it keeps on being a journey for continuous improvement. Also GS1, this is something that's going to be mandatory in Europe. It has to do, again, with contrafaction and with patient safety. It's barcode enablement and having a single code for drugs and medical devices. We have adopted it since 2015 and were awarded the best case study implementation by GS1 itself. Benchmark, I would just point out that we put ourselves against every result, every credible result that's out there, and give our data in order to compare ourselves and make sure that we follow whoever is leading the market. So innovation is not only by putting stuff that's just new, but sometimes innovative just by copying who is doing the best in their class. So best in class for us is innovative. So we keep on benchmarking us against everyone. So we've been recognized in Portugal by receiving these awards in the past few years. Naturally, as I said in the beginning, we are evaluated by the quality of care perceived by our patients. So we evaluate how the patient sees us, and we do it by 2 ways. Basically, by having an annual patient satisfaction survey, which is that 8.5 that you find in the lower right corner, and also by measuring the Net Promoter Score in several ways or in several areas of the hospital. Naturally, 53 is not something that's extremely high, but as mentioned before, we're like the Italians, we're grumpy people. So the Brazilians sing samba, and then samba we sing fado, so it's a sad song. So 53 for Portugal is kind of a neat stuff. And more than comparing against the world, we're comparing against ourselves and making sure that we follow the feedback that patient gives us, incorporate those, and keep on evolving over ourselves and making sure that we are better tomorrow than we are today. And then sustainability. We're moving to the third corner of the triangle, right, of the triple aim. We need to be sustainable in the long run. So one of the things that we want to make sure is not only that we are sustainable as a company, as an operation, as the hospital operation, but we want to make sure that we are sustainable for the system. So one of the things that we've measured is the value for money for the government. And value for money for the government is evaluated by how much does the government saves by having a PPP running that hospital. And according to the latest evaluation, we save something like 24% a year, which in our budget represents something roughly 17.5 million year on year. We spoke earlier about happiness. I believe this was the first conference I've been where we spoke about conference, and we're not in Finland, so I believe we're going in the right direction. We also have a happiness committee in our hospital. We do measure the happiness committee index. We're evolving from what we've studied. More important than where we are in different geographies is where we are versus yesterday and where we want to be tomorrow. So basically what we're doing is we're incorporating from our employees insights from how they do their work-life balance or their work-life blend, if you want. And we're some of the initiatives that we're putting together on the left side of of the screen, and those come from feedback that our employees have given us. Again, and now the case study itself and some of the examples. We do believe that quality drives sustainability on the long run. If we do not have quality on the long run, and I believe data that was shown here today shows that. If we don't drive quality, we won't be sustainable on the long run. So here is just some examples on, and now I think, okay, here we go, on how much does it cost to have technology in place in order to drive quality. So one of the things that we were, I would say, lucky is that we started at a maturity level, a high maturity, technological maturity level. So the gap to get to a stage 6 was not that far out, and we didn't have to invest much to reach a stage 6, and we've done it with all local vendors. So what we've done is there was not a off-the-shelf product that we could use in order to reach maturity level. We could not buy maturity here. We had to develop. So some of the things that we've done is we've created some new functions like the Chief Medical Information Officer, Chief Nurse Information Officer, Chief Pharmacist Information Officer. So all of these specific delivery functions had to create their champions in using technology and had to evolve their teams in order to reach this maturity. In terms of the return that we're measuring there's a lot of avoidance there, a lot of errors that were avoided, a lot of near misses that were avoided. And of course, one of the things also that's returning a lot in terms of the using of technology is the average length of stay. We're reducing in all the areas that we're putting technology into place. We're reducing the average length of stay and therefore reducing intra-hospital infection, mortality. So by keeping patients out of the hospital and having early discharges, we're keeping them safer. So now we get to the very narrowing down to the example. So this is proximal femoral fracture. So it's basically what we've done is we created a fast track from the door of the emergency room to surgery. And we were able to come down from a peak of about 80 hours that was taking us from entering the emergency room to reaching the surgical table, now down to 36. The national benchmark, or the gold standard, if you want, in Portugal is 48. We're at 36, and we're aiming to reach 24 by the end of 2019. So this has to do with the speed of how the system is calling all specialties, nurses, asking for exams, for blood analysis. So all of this comes directly from the system. There's the tree of decision over there that we translated into the system. And one of the other important data has to do with the in-hospital mortality rate, where we have come down from a peak of 8% to about 0.2%. National benchmark is at 6.2. With our high care project, basically what we've done, more than just clinical quality, we also want to have humanity with the care that we're delivering. So what we were aiming when we started to put technology in the hands of nurses and making sure that they were doing all their work at the bedside with PDAs and with barcode enablement, we wanted to save time for medication purposes, for example, in terms of the time that was taking each nurse to deliver the medication. But after reaching that objective, that initial objective, we wanted to make sure that we were translating this objective for the organization into benefit for the patient. So we start measuring the NPS for the inpatient ward, so before and after the project. And as you can see here, the NPS has been going up since we've started the project. And last but not least, just the way we look at our patients, just the quality of our systems and how we are selecting important data from each part of the system and making sure that the doctor or the physician in front of the patient has all relevant data in front of him. It has to do with the number of diagnoses per discharge. As you can see, both greens is Cascais and Cascais year on year, and the blue data, or the bluer, is the national benchmark. As you can see, performance is quite different from the rest of the system as we speak. So this has to do with the quality of the information system and how we are selecting important data and making sure it's available for doctors at the right moment. And finally, lessons learned from this digital journey. So there has to be an alignment with the hospital. I spoke earlier about how the system needs to be aligned with the operator, and then if you want to follow a technological pathway, it needs to be aligned with the top management. So it needs to be a driver for the whole organization and not for one specific part of the organization. Then people engagement. We're speaking about doctors, nurses, technicians. All of these have specific ways of communicating. One of the key success factors is learning how to communicate correctly with this kind of population. So we found that by selecting champions within our own organization and having them communicating with their peers was very relevant to the result. Then focus on continuous quality improvement. We have to create this virtuous circle where you're never there. You're always seeking for new best practices, new ways of achieving. As I showed you with the proximal femoral fracture, the benchmark was 48 hours. We're seeking 24, and we'll keep on making sure that we're always following the next objective. Proactive change management. I believe this is on a day-to-day for everyone that leads an organization. We need to make sure that we are foreseeing the difficulty in advance. So we need to make sure that we are seeing where we're going and where we need to change and where action needs to be taken. And finally, and very, very important, when in big organizations and in small organizations, we need to celebrate success. So small successes, this is a long journey, a very tough one. It takes a lot out of everyone. If we don't celebrate small successes, we end up by having the whole team desperate to reach a never-ending goal, because we're never quite there. Once we reach this goal, there's always the next goal. So make sure that you celebrate successes as you go forward in your digital journey. And that's it. Thank you.
Great, thank you very much, Vasco. One of my thoughts about when you were talking was, and bearing in mind our Secretary of State for Health's top-down edict about pagers or bleeps and how we're not meant to have any soon, the balance between you working in a hospital, designing your own systems or taking the initiative, and what's coming down from the top. I mean, we're very conscious of that sort of thing in England and the NHS. I just wondered whether you could say something quickly about that, yes, in terms of the whole implementation of digital and so on. Yeah,
so I think the communication part of it, the its and bits of communication, it's part of that we're all following. It's a trend, a worldwide trend. We have some top-down initiatives that we need to make sure that they are somehow leveraged and maximized within the organization. But then we need to make sure that we are the ones that are being built bottom up, that we are communicating the success and the value for the patients and for the systems with that with the leadership of the system, to make sure that it becomes a top-down initiative for the whole system. So we definitely need to make sure that we maximize both top-down and bottom-up initiatives.
And do you feel you have enough freedom at the sharp end to do the things you want to do?
Well, with our model, yes. I believe that, for example, the normal model, if you want, in Portugal, has a lack of freedom. So it's a very mandated system, and the very mandated takes out all the innovation and all the proactiveness that you may have within each organization. I believe more liberty of action with those organizations would be beneficial for the whole system.
Okay, so we'll just open it out for a few minutes, then we're going to go into our sort of panel discussion. I've got a question there, then I've got Nigel at the front. Yep.
Thank you very much, Nina Modi, Imperial College London. That was a very nice illustration of what is happening at a local level. But I have a question to you about the impact of the model you've described at a national level. And the reason I ask this is because there is very good evidence that having a parallel public-private healthcare system is progressively destabilizing to the public healthcare system. Now, you've described private running of a public hospital. And so my question is, what can you tell us, or what evidence has been gathered about what impact this might be having at a national level?
So just to make sure I understood correctly, the question has to do with how have two systems working side by side is not basically hurting the public system towards the private one? Is that the question? Okay, so basically if we have a complementary system as we have it in Portugal, what happens is there is a gap between what the government or what the public system can do given the constraints that they have, for example, the financial constraints that they have, and that the private sector can add. So what we've added in, what the regulations that there are in place in Portugal regulate more about, for example, the usage of the emergency room and the high acute patients. So emergency room, high acute patient, we just mentioned earlier, the ambulances and the usage of the fire department's transportation for emergency usage. That's all publicly managed, and the private sector will not touch that part of the healthcare environment, given that they are high acute patients and basically they have to be centrally managed by one central system. I would say that as we are today, we have not reached an equilibrium in Portugal, so between the public and the private, and that has to do with the total spending and the crisis that we've spent in 2012, and we're still adapting a little bit with the growth of the private sector in Portugal. So I would say that as I see the system working in the future, we'll have more increased accessibility created by the private sector, more outpatient visits, more ongoing maintenance of health, and more of the acute part of the system being delivered by the public system.
Nigel.
So I have two quick questions. One is about the extent to which your system links to family doctors' primary care. And the second is Atul Gawande wrote a great article in the New Yorker just before Christmas called Why Doctors Hate Their Computers, saying that there's a widespread epidemic across many American healthcare systems where the systems are bad to use, they make people's lives worse rather than better, and that you can even quotes an advert for a job in an emergency department which said no electronic health record as one of the selling points of the job. So I wondered if you could just say, how happy are your doctors, or do they hate their computers as well?
Yes. I like the happiness committee. Are the doctors in there as well? Sorry. Yeah.
Okay. So the first one, and then I will leave Anna to answer the second one. She's a doctor, so she might be the more appropriate to answer. So the first about how we integrate with the primary care. What the government created is something very useful, and even HIMSS Analytics has taken the example and trying to move it to other geographies. It created a platform between all public hospitals and all primary care centers, where everyone has a view over what is being performed for that patients in different hospitals. So I can see in Cascais if the patient has had an MRI done in the next hospital, and instead of just repeating the MRI, I can access the data and make sure that I take my decision without having to double perform the same action.
It's a read-only platform. And the GPs can also access all the information that has been taken place at the hospital. Emergency room visits, consultation visits, inpatient stays, they can access all of that.
Do you want to answer the other one?
Yes, I think I should.
I should introduce you. Sorry, can I just quickly introduce
Yes.
our panel now? Because we've segued, but not quite seamlessly, but into the... Ana Rafaela Prado,
Yes.
Chief Medical Information Officer at Cascais. Tara Donnelly at the end. I'll ask them to say who they are in terms of their work, and our own Sophie Castle-Clark from Nuffield Trust. But Anna, do you want to just, say something on this?
Yes, well, since we went back to the introductions, I just want to thank you for the opportunity of being here. I've really loved everything that I've heard this morning. I think it's really impressive. And I just want to say that it's amazing to be here in this room with so many leaders with so much experience, and I really believe, and this has to do with the journey that we've been on, that this exchange in information is really what makes us also move forward. Now, to answer your question specifically on doctors hating EMRs, I was one of those doctors, I have to confess.
There was a slight hesitation there.
I was just wondering, am I going to be fired if I admit this in public? But, and I wasn't really convinced that, and this was back before we went on this digital journey, and I didn't really understand why my CEO challenged me to be our CMIO, because I was interested in technology, but I wasn't really, clicks on the computer, and I'd rather be with the patient and spend time with the patient than be doing clicks on the computer so someone could do something somewhere with the data. So I think you get two extremes, and this is what we have nowadays. I think like in the US, you do have an extreme with a lot of systems that physicians spend the whole time looking at a screen and clicking, and that's not what we're trained for. That's not the point. I mean, I'm sure everyone is about big data and everything nowadays, and sure, that's important, but you can't just look at that aspect of things. And one of the things that I was fortunate enough to be able to do in the Lusíadas project was that we were able to, clinicians were empowered to influence how we wanted our EMR to work. And one of the key things that I believe was determinant for our success and how we managed to MRAM is just a guide map. We chose this guide map because we believe it makes sense, because it's proven to bring benefits for patients, and that's what doctors and nurses want at the end of the day. So but by involving people all over the institution, not just doctors and nurses. So we created several teams. The board empowered us to do this, to create teams. And so we called people from, I don't know how the equivalent word in English, auxiliary staff, nurses, residents, consultants, all the way bottom up to give their opinion, and we brought in we had the freedom to bring in all the people we thought were necessary and part of the process, and I think that's key. I think I answered your question.
Yeah, I think you did very well, and it was great. Tara, NHS Chief Digital Officer for NHS England, do you want to have some observations on this, or you have some observations?
Yes, I'd be delighted to. So it's fantastic to hear from a HIMSS Level 7 organisation. We look to those organisations, and people will probably know a little bit about the Global Digital Exemplar programme in the UK, which has been going it's now in its second year, and essentially it's to help a number of trusts go on exactly this journey. And I was really interested, John, that you used the word autonomy, because the way it has been delivered is that trusts have been given quite significant amounts of money, between 5 million and 10 million each, to become more digitally mature, but the way in which they do that is entirely up to them locally. One of the requirements, though, is that they must help spread the learning. So they must have fast followers who will learn from what they're doing. And I was interested, when we were chatting just now, to hear that 2 of the global digital exemplars have been linking with you in Portugal to do some of that learning, because it is supposed to be a global learning community. And I think we're starting to see some really interesting results from that global digital exemplar work. It's had £300 million so far. Another 200 million is committed for the year ahead. So this is quite a big investment being made across the NHS. And we're starting to see some of the results that were referenced to do with safety improvements. And I think one of the things I would say that I was just thinking as Anna was replying there is it just gets much more clinically interesting as you go up those numbers. Because the lower numbers you are replacing a PAS, really. You are getting the kind of bones of it working. You start to get the exciting stuff that actually starts saving clinical time later So I think sometimes when people are finding it really hard at work, it's because it is adding to their workload in those early stages and they've not yet got the benefits of later on.
Sophie, let me bring you in. I was thinking, in my introductory remarks, I said something about not necessarily moving from analog to digital, but to maybe from old to new digital, or maybe even to appropriate digital. And I was partly thinking, I told you this earlier, thinking of my dad, who's 93. For him, high tech in his house is not a smartphone, or he does use an iPad and so on. It's post-it notes, right? So for him, it's having bits of paper with a bit of glue on the back that he can stick up with notes for himself. So that, and it's really appropriate tech for him. And I'm just wondering whether there's something there that we can get. We can get a bit sort of thinking of very flashy, latest things, whereas what we've really got to think about is, in a way, having a digital strategy, that's maybe the wrong way to think about it. It's just a strategy for improving your key performance indicators in the best way you can. Sorry, have I actually asked and answered my own question there, Sophie? So I went on a bit there.
Give it one perspective, certainly, John. There might be others.
Anyway, you could have some other thoughts on all this. Yeah. So I massively abused my power of chair.
I think it's a good point because we've been undertaking a bit of work over the last 6 months where we've gone to visit 6 acute trusts across the NHS. We've got global digital exemplars and fast followers and also weaker trusts digitally. And we've been specifically asking them sort of what they want from national policy, how they think the national policy is working for digitisation. And one of sort of the expectations or one of the hopes for the global digital exemplars is that they will become HIMSS level 7 hospitals as well, so really digitally advanced hospitals. And one of the things we've heard back is that while they think it's important to be able to strive for digital excellence and to use these international frameworks to measure that, that running to achieve HIMSS level 7 as quickly as possible isn't necessarily what they feel they should be doing, and it can detract from embedding sort of digital in more slowly and ensuring sort of patient safety and quality of care is improved sort of in a more gradual way where you bring the workforce along. And I think there's a question about, yes, we do want digital maturity and we want to advance quickly and get all those benefits that you've talked about, but how far we should be striving for the really, really advanced levels of digital maturity as quickly as we possibly can versus take our time over that journey a little bit more.
Should we open it out a bit more? I think I've got a question here, Andy. And then Anita, and then, who's that? Oh, Caroline, sorry.
Andy Cowper from HSJ and Health Policy Insight. In the Cascais example, how long did it take you to fully implement this new digital system? How did you deal with those doctors who, like you, originally were more reluctant to come on that process? And how much did you rework the ways in which departments and teams did their clinical practice? How much did you review your systems as part of this implementation? And to Tara and Sophie, what are your observations looking at how the NHS implements digital change and sharing of information more openly?
That's a massive bumper of at least 4 questions you managed to squeeze in there, Andy. Well done. Do you want to quickly address the
Sure.
sort of time? Because I think that's one of the things that when one system looks at another and we've achieved it, and you don't always get an impression of how hard the slog was and the journey and so on. But do you want to say something about that?
Well, like it was said this morning, this much more than technology, this is about people, patients, clinical workers, business people, board members, etc., etc. And because of that, the most important maybe catalyst is communication. If you don't have communication, then nothing will get done. In terms of time frame, and I think each institution is different. For example, we were lucky to be able to speak to some folks from Southampton, and their hospital obviously is a different dimension, a different care profile than we are. So I believe, and it makes sense, it's logical that in our hospital, being a smaller hospital, it would be faster if all the pillars are working, you know, than in a much bigger hospital. However, like it was mentioned before, if you don't communicate the benefit, if you don't take the time to explain to physicians and nurses and whoever the benefits that this will bring to their practice, because there's always a learning curve. I mean, a surgeon has a learning curve as well. So why not this? You know, so I think it's much more about how you communicate and explain and involve the people in the project than, you know, oh, we did it really fast and they did it really slow, and they, you know, keeping in mind patient quality and safety. I really think it depends on the institution.
Can I just add a quick comment? So when we adopted the EMRAM, the reason why we adopted it, this is before Anna was Chief Medical Information Officer, we adopted it because we were following blindly the 5 rights for drug administration. So basically we had technology, we had the 5 rights, if you want, saved within our system, but the system was not helping the professionals. Once you take a look at what the system was doing, basically was a barrier between the professionals and the patients. And at that point, what we've challenged the teams were either we improve the system and we bring this technology into a real and actual benefit for the patient, or we take it out and we go back to paper. Because if we're just putting technology in order to make sure that you have, and we're speaking about post-its and the right amount of technology. Beforehand, we had the wrong process for the technology that we had. We had to reshape, do the re-engineering of the process, rethink the process, and readapt the technology. And once we finished, that's when we asked the HIMSS Analytics to come over and audit where we were. Yeah. So there was a kickoff, an incentive to, technology was a barrier at that point. So we had to take it out or improve it.
And we had ideas to even implement more technology, but we had to go back because it would never be implemented in a safe way and in a way that the clinical team would adopt it.
Now, I've forgotten the question, Andy, you had for Sophie. Sorry, no, Sophie and Tara. What, in a nutshell, was it again? You've forgotten as well.
I've remembered.
Can you remember it, Tara?
Just,
yeah.
I wrote it down.
Observations about how the NHS goes about digital introduction implementation.
Okay.
Do you want to go first, or shall I? I was just going to say that Vasco and Anna are probably too modest to say something that I would say in response to your first question, because I think you did it really fast and really cheaply, comparatively. So I think you should be congratulated, but you can't really probably just say that because it's like it wouldn't go down well. So I want to say a couple of things in response to Andy's second question. There's a huge amount about this which is about leadership. I still see something which I think needs to become unacceptable, which is people in leadership positions saying, oh, I don't really know anything about technology. Yeah, I don't think that's good enough anymore. I think we've got to move past that. And I think the dialogue is changing happily. It's becoming a mainstream thing, and it's a question for people not about if, much more about how do I do this as well as possible. And I think that's really incredibly important, and that leaders have a big role in making that so. And I also want to make a response about, I think it is very important that it's not about chasing numbers around getting more digitally mature, but the big striking difference to me is that you can tick the box for HIMSS level 6 if you've got electronic prescribing in one ward of your hospital, or you've got barcoding in one theatre, right? To get to 7, you have to have it everywhere. that's a huge shift. It becomes mainstream routine care for everybody in that organisation. So I do agree that it should be rushed and so on, but I think it remains a really important ambition, because we don't want pockets of isolated, digitally wonderful bits. I remember visiting a Warden hospital where somebody was overjoyed, and I just happened to come across the nurse in charge to talk about wireless vital sign monitoring. It was game-changing. They had a situation where the crash team were down to help a patient before anybody had even twigged what was wrong. They had it in 3 wards of that hospital. They were desperate to have it in the rest. And what level 7 is, you have to just have that everywhere.
I want to bring in some more people. Anita's been waiting, sorry, and then there's Caroline at the back. Then we've got Sarah, Alistair. Sorry, there's too many at the moment. Right, but I've got you. Yeah. Right.
I'm going to channel my inner young person in this question.
Watch it.
Respecting that there aren't many in the audience. So I had an exchange with someone under 30 recently who had the misfortune to have to go to A&E in a city where they didn't live. And that A&E couldn't look at their record for other hospitalisations over the recent time period. And what was quite interesting about that was the person felt that really worried about whether or not they could have any confidence in the quality of healthcare being delivered in a system that couldn't, in the 21st century, provide access to A&E records across a network of 200 hospitals. And for them, it wasn't nice to have. It was a basic question. You're telling me that all this stuff that they're going to do to my body, I can trust them on when they can't organise a basic bit of record sharing. It's quite a hard argument to counter, and I'm very conscious that I don't think this sort of thing is tangential. The biggest, when we did work a few years ago with the public concerns about inefficiency and waste, as people interacted with the system, they get a lot less confident that the NHS uses resources well, and they get less confident over a lot of these basic hygiene factors, to use the Maslow example, and the rest of their life is getting more of these hygiene factors right. So their bar is increasing because it's a relative bar. So my question is, how long have we got before we consistently get the basics right? And there are two elements to how long we've got. How long practically is it going to take us? And how long will the public tolerate our failure to do this? And if those are out of line, what on earth are we going to do?
Thanks, Lisa. Before you jump in, I want to bring in Caroline at the back just to get some more views from the floor.
Thank you. So it's Caroline Clark from the Royal Free, and we are a global digital exemplar, which I like to think is a sort of future conditional state. So I want to echo what Anita just said, actually. Some of this stuff is as basic as having a roof over your A&E, and I think we absolutely get that. I wanted to talk about 3 things. One was to echo what Sophie said about getting the basics right, because having just opened a new hospital and had the benefit then of putting in a whole new EMR, which we hope will certainly be HIMSS level 6 and then HIMSS level 7 next year, I understand that that is a really hard thing to do, and actually I can't do it in one of my other hospitals because we have to spend a ton of cash on the infrastructure and the wireless and getting the kit out. So even before we get into the change management, so I absolutely get that. I wanted to reflect on our experience, actually, of putting in a new EMR, and we put in a big American system. Other systems are available, but it's a change management process, isn't it? It's absolutely not a technology piece, and you have to let the clinicians run it. And our reflection was that you also have to do clinical process optimization before you do that. And we've learned loads from places like Intermountain and other places, and I hope we'll learn from Portugal as well. The game changer, of course, for us is having better data. It is having a system that allows us to understand the capabilities of the people that are using it and their clinical practice, and we have massive insight into that in a way which we just didn't have before. And the second game changer is the empowerment of patients. So the particular system we've got has a patient portal, and And if we can get that being used by the majority of the patients that use our services, we've absolutely changed the way that people engage with us. And that's really a prize that I can't speak highly enough of. I wanted to take a bit of issue with something you said, Tara, about we were talking about the Atul Gawande article. I don't know about you, I had it sent to me 19 times as we were putting in the EMR. And I think that the thing for me is there's clearly change fatigue as you put these systems in. But I think the other thing he pointed out was, of course, as you've got them, and I think it was what you were saying, Anna, there's just digital fatigue from sort of tapping the system. And I think the work that people like the Jocelyn Cornwall's doing in a Point of Care Foundation, trying to get the sort of relational aspects of healthcare back, you have to do at the same time as putting these systems in, and that's something that we're learning as we're doing it. The final thing that I was going to say, I couldn't say this coming from the Royal Free and not say it, is obviously I wanted to ask Vasco actually around information governance, data security, how you protect your patients' records. We've had some experience of this with the Information Commissioner in the UK, where we work with Google's AI provider DeepMind, and we have to get this right in the UK. We've got a long way to go in how we use patient information more effectively. So I'd just quite like to understand what the Portuguese experience is.
One more question, then I'll remember some of these points and come back to the panel. I've written them down on my with my analog pen. Sarah, so please say who you are. I forgot to say it, yeah.
Sarah Scobie from the Nuffield Trust.
Can't quite hear you. It's on.
Sarah Scobie from the Nuffield Trust. So a lot of this is about change management and engaging staff, and I wonder what the panel thinks about the capability of the NHS for quality improvement generally, and whether that's a limiting factor in our ability to make the best use of digital.
Should we take Sarah's point? Anybody want to pick that up? Sorry, Sarah, no answer to that one. Let you think about that one. Let's go back quickly to Anita's point about the... it's partly about sort of different generational expectations about things, isn't it? And I'm trying to think of, what my kids and what they use and the things they do and so on. But anyway, there is something about that. Could there even be the public's pressure for sort of change and so on, drive some of this stuff? Tara?
I think it's more than generational. I think many people expect that the NHS is already sharing their data for good care. And they are surprised if they rock up to an A&E, as Anita's just described, and other than basic demographics, people don't know the first thing about them. So the way that the system is trying to do something about that is through the local health and care record exemplars, so bringing together at population level. So one of them, for example, is across the population of London. All types of providers with information from health and social care, to bring it together to both share for clinical practice and for patient lookup and ultimately for research. It's a piece of work that's only begun relatively recently, but the first bunch of funded LICRAs, as they're called, will cover about 80% of the population with plans to cover the rest subsequently. But you're absolutely right. On a practical level, it is so frustrating that we don't already have this. Parts of the country, of course, are much further ahead than others on this, including on having patient portals so that people on their smartphone can look up their health information. And we've got a number of parts of the country that are doing that extraordinarily well, including actually Southampton, who got a mention earlier on. It's incredibly frustrating we're not further ahead, but it does feel that finally something is happening to try and work out within the kind of sphere of diameter of trust, they call it, so not sharing necessarily your information with everybody across the country, but sharing across the providers you use most. So I'm optimistic that that's going to improve, but it will take a little while.
Thank you. Vasco, do you want to say something about the data protection, privacy issues? It's taking off almost exponentially here and in other countries, I think.
Yes. I would say that about data and data protection, data sharing, if we think about how the model was built, and from a policy standpoint, what policy drove, I believe in the NHS should be very similar to what happened in Portugal, was mainly built for being B2B, doctor to doctor, organization to organization. And what we are assisting with what we're seeing happening throughout the world is it's becoming B2C. Basically, what's happening, is it working?
Carry on, it'll start working. So there's a man coming up to fiddle with your digital attachment. So if I can put it that way. Oh, well.
So basically what we are seeing throughout the world is the model is becoming more, the system needs to become more B2C. We need to give that information, the clinical information to the patient. It's individual health records. So there is a lot of change within our system in Portugal because of GDPR, naturally. I think it's happening throughout Europe. The system itself, it's evolving. When I'm in the system, the national health system is evolving. But remember that we do not have one single national health EMR. So what we have is several EMRs. What the government created is a platform that connects all of them. So basically we have viewers of others' EMRs on that patient. So the platform allows doctors to be within one of the NHS hospitals, log in and go through the patient's individual health number to his information throughout the system wherever it is.
If the patient allows.
If the patient allows, naturally.
Thank you. I want to get, because there's been a lot of hands up. So Alistair, and then right at the back, yeah, and then John, is it there? And then, yeah. Too many.
Alistair Henderson from the Academy of Medical Royal Colleges. It was really just about, I suppose, a bit refining the sort of doctors hate computers line. I mean, I think it's doctors hate computers that don't work and make their life harder. Actually, that as you were saying, that is it something that makes delivering clinical services better? And I mean, we're just about to start, or are starting just a bit of work talking to doctors. One about sort of what they identify as the opportunities for digital transformation and also the barriers. And we're slightly anxious that our white box for the barriers is going to have to be rather larger than the other one. But it picks up Caroline's point of having to be honest about acknowledging, about getting the basics right, because I don't think that we'll be taken seriously for people who can't get the information not just from an A&E across the country, but from just in around their own area, unless we're absolutely honest that the basics have got to be right first, because people will just say, don't talk to me about whizzy AI systems if I can't get records from my system. And I think us being honest about that is essential.
I'm going to take a few more. Right at the back, sorry, just say who you are. Then it's John. Can we have the microphone down here as well?
Ray James, National Director Learning Disability at NHS England. Slightly different tack and a question about the extent to which health inequality can be a conscious driver for the implementation of digital systems. Is there any learning perhaps from the Portuguese experience about what you've been able to do to make sure, for example, that people with intellectual disabilities will get the small reasonable adjustments or changes in their treatment pathways that they need? And more generally for the panel, most of the narrative that I hear tends to be predominantly about efficiency and clinical gain and not enough about the potential for reducing inequality. And I'm fearful that unless it's an explicit aspiration from the outset, we compound and exacerbate the inequality rather than seize a great opportunity to reduce it.
Okay, so we just hold that thought about the inequality in tech. And John, do you want to?
Yeah, so it's a change in tack, really. So I was beginning to feel mildly cheerful after the first two sessions. And I feel as if I've gone back a bit in time in this session because apart from Nigel's question and Tara mentioning system, most of the conversation's been about hospitals. Now, to be fair, the case study was about hospital, but there's been an awful lot of questions and conversation about hospitals, patients. It'd be great to hear some stuff about how digital can enable us to think about people, to think about the biggest consumers of healthcare, which is people with long-term conditions, and all of this kind of stuff is. I've got this terrible sense that we, because we've made such a hash of digital in the NHS, is that we'll just try and replicate hospital-based systems rather than actually skipping a chapter and thinking about the new world?
I thought I did mention my dad's post-it notes in the community.
I loved your dad's post-it notes.
Do you want to pick up on the Sophie, Tara, in terms of the inequality issue? It does crop up, doesn't it? In terms of, I don't want to keep mentioning my dad. I mean, you know, but there's a point where, you know, at a patient level, the technology may be a bit of a barrier and so on. But
well, I think when it comes to patient technology, the point is that it's around choice, so people being able to use sort of patient-facing apps and tools and services. But I think there's lots of work going on to make sure that it's one option and that people aren't necessarily forced down the digital route. I think there are other also opportunities for digital to sort of help people and bring people sort of more in line with each other, particularly through, for example, assistive technologies, through things like peer support networks online. So I think it doesn't necessarily have to be a divide. I think there are ways for it to kind of level the playing field as well, and it's about getting that right and allowing people to choose what works for them.
Yeah, I'd completely agree. And I think one thing that has made a change in recent years is the pervasiveness of smartphones. It's now, so over 81% of UK adults have a smartphone, and in 18 to 44-year-olds, that's 91%. So that's really helping, because there are a number of opportunities where digital can actually help close the health inequality divide. I haven't talked at all about the programme I run, which is called Empower the Person. I was delighted Caroline Clark gave it an actual name check, which is all about the people-facing stuff that John just mentioned, because this is mostly about, you know, the issue of how you get to global digital exemplar status. But the opportunity there is enormous. So we spend 70% of our NHS resource on people with long-term conditions. That's both time and energy. We spend almost none of it in the early stage. We spend it almost all in complications of the disease. We now have a small number of digital products that are so, their evidence base for them is so high, we can call them digital therapeutics. They're making that much of a difference across at least 5 chronic disease areas. If we were just to go after that at scale, we would see the most enormous difference. I'm seeing some interesting results of the diabetes prevention programs that have a digital element. So I think that journey is happening, but you're right, it's totally exciting, and that's the way we're going to reach many, many more people. This conversation was particularly about looking at the kind of international comparison on GDEs, but there's a whole story to tell about that other stuff as well.
Question at the back there.
Thank you. Anita Donnelly,
one next door to you as well.
Chair of the Mid and South Essex STP. I'm hearing quite a lot of concern from my colleagues in local government about interoperability and accessibility. And I think there are 2 implied questions there. One is, to what extent are we confident that the global digital exemplars will address that true integration across health and social care, and thereby embrace the opportunities around population health agenda? And the second one is, how good is our communication with our local government and social care colleagues around this whole issue? Thank you.
Anybody want to pick that up?
I'm happy to, but I don't want to hog it.
Go on.
I think GDEs are very involved in that, but I actually think it's the local health and care record piece that is really doing the interaction between social care and health care. And that's a really big programme of work, and as people in this room will know, it's not easy. It's been tried before, but not quite in this way. But it's absolutely trying to tie in all of those aspects so that we can move towards a population health management approach. That's not to say that there aren't STPs and ICSs out there already doing some really, really interesting stuff around population health, but we're yet to do it really as a country at a bigger level.
Can I say something on data sharing more generally? Because I think, like you say, it's come up a few times. It is still one of the big outstanding issues that you hear about, and IG is a big concern, and it's often GPs and primary care colleagues that are resistant to share data because of concerns about IG, and there is work in that area with the IG framework that's being developed by NHS England, which will hopefully try and simplify some of that and try and give people confidence about how to share that data. I think there's also a really interesting technical point about data sharing, which is that it links in with what I was saying earlier about rushing to HIMSS level 7 status, is that we're trying to mandate quite advanced technical open APIs at the moment that will allow kind of seamless data sharing across the sector. And we're doing it when the system isn't ready for it, and that's sort of hindering things that are already going on. So at the risk of sounding quite dry, I think it's a wider point about trying to rush to something, to put something in place that the system isn't ready for when the basics aren't there. And as you say, a lot of it's about that communication, concerns about IG, bringing GPs and social care colleagues on board before trying to rush to mandate kind of the technical solution, which isn't ready at the moment to be working in practice.
Can I just say something about, I've just been to the United States to the HIMSS conference in the US a month ago, or not even a month ago, and I was fortunate to listen to the previous CTO of Obama, so the Chief Technological Officer of Obama during the Obamacare, and the whole technological framework that he had to design. And they've injected billions of dollars into the system in order to increase interoperability and to increase APIs and to make sure everybody connected to everybody. And they failed. They keep on injecting. There is a lot of money still flowing to the system in order to make sure that they are evolving in interoperability, but they're failing. And he recognized that the way that they went about it did not make any sense. So what they've said was the single most important action that is moving interoperability forward within the NHS is, and I found this very interesting, is the Apple Health, the app that we have in our iPhones. And basically what the Apple Health states is they basically state the level of the framework that it needs in order to receive data from hospitals and from private providers. And it will receive only in HL7 through FHIR. So it's mandated a standard to say, I will only receive data in this way. And everybody else just start moving forward in order to create an interoperability standard in order to show in that app. So because everybody wants to be in the Apple Health app, they're all moving forward into the interoperability, following a global standard that Apple just decided to follow. So the government has moved billions in order to make sure that everybody aligned, nobody aligned, and then Apple said, if you want to be in my app, you need to follow HL7 and FHIR and connect in this kind of standard. And now everybody is following it. So it's definitely, sometimes you have an Uber effect. There's a new kind of model that comes into the market and moves the market forward.
Just on that breaking news, I've walked 0.63 miles today. I can't quite believe that from the bedroom down here. Sorry, at the back, sorry, we've been waiting, and then there's, I think we'll take the one more behind. So there's a woman in black there. Sorry, can't quite see.
Maxine McIntosh. I'm an AI researcher at the Alan Turing Institute, so it's very nice to have a much more sensible conversation here than about whizzy AI disrupting everything. John, you started this with talking about purging the pager, and the pager is just one of the 3 things currently being purged, including fax machines and paper. And it's really nice for a techie geek like me to have and hear a Secretary of State so passionate about digital. So I wanted to ask, and I would include you, John, in being able to answer this question, what are the downsides of having such an potentially overzealot Secretary of State for digital?
Tara, no, let's go. It's sort of, that partly reflected my question.
Like it might be someone else.
Yes, I know. It's partly reflecting that sort of top-down, bottom-up thing. I mean, should we just leave that to...
Returning to the foreigners.
Any views on that? No. Let you just think about that, and then...
I have a few thoughts.
Yeah, okay.
I think from the the site visits that we did recently, there is a concern, even among these kind of quite digitally advanced hospitals, that it can be sort of undermining trust and faith and confidence, because you're just talking about the whizzy gadgets, and it doesn't sort of ring true to people's reality on the ground. And people, I think it undermines kind of the progress that's been made on bringing clinicians on board, and seeing how sort of technology can be embedded in more of a sensible way. And I think actually it relates to a point I was going to make earlier. We've heard from the Portuguese experience, and I think it's something that's come through a lot in the NHS now, that you do have to bring your clinicians on board. You have to engage your clinicians and your clinical community in terms of seeing the benefits of digital. And that's a lesson that's been accepted, but it's not necessarily translated through to sort of national policy. So I think sometimes national policy is set, mandates are set, and the reason behind them isn't clear, the rationale isn't clear, and the benefit that they're intended to bring isn't clear. And we've seen that quite a lot with standards and mandates for technical digital solutions as part of this project. And what it often results in is those just being completely ignored, or workarounds being put in place, which means that benefit isn't realised. So I think that it can be quite destructive, and it takes away quite an important lever. So the disconnect between national and on the ground is really fundamental to sort of, well, we need to overcome that disconnect to achieve successful digitisation, I think.
Let me take this one more, and then you'll be the final one, I think, because we're running out of time. So at the back, I think there was somebody hand up. Yeah, you've got the microphone. Yeah.
All right, great. Yeah, sorry, thanks. So I'm Ronnie Chung. I'm a general paediatrician in London. I have a question for the panel, I guess, about the pace of technological change and sort of digital sustainability bit, really. So you talked a little bit about how there were a sort of a change of model in how technology sort of changes the entire way in which we deliver lots of ways in which we live, so the Uber model and all of that. And I guess my worry about this is that we're talking about a lot of upfront investment for a system here at the moment which is under a lot of financial strain, and we're sort of having to plan ahead a few years to think about what the future is going to look like. There's big upfront investment for now in lots of electronic medical record systems that are built predominantly in the US based on platforms that are 10 or 15 years old. And so by the time we put them in, and then we're going to go ahead and do that, what's to say that in 5 years or 10 years, the whole model changes it completely? And what kind of thoughts have you had, particularly in your journey, as to how you think about this as an iterative and continuous process, and balancing that with the fact that there's a platform change?
Thanks, Ronnie. Just behold that, because I want to get one more question in. A woman in the middle, if you put your hand right up, the microphone will come to you. Yeah.
Hello. Oh, my voice. I'm Gabrielle Matthews. I'm on the NHS Youth Forum, and I guess the young person in the room. And I'm also a medical student at Imperial, so that's one of the digital global exemplars. So we've spoken a lot, and I think people have now started to mention the patient side and their experience of care. And I was wondering how in Qashqai, you mentioned happiness and how the patients are feeling, but I was wondering if you'd had more discussions around how they feel around the changes in systems, and whether they notice it, or whether it's merely the professionals that see the changes and the changes in outcomes, and the patients haven't really noticed the changes that have occurred.
Okay, great. So there were two there. There was one about sort of obsolescence and maybe fads and changes and so on, and one about now I've instantly forgotten. So, so could you say again?
Patients
sorry, yes.
The benefits.
Yeah. So do you want to, as we round up now, we've got a couple of minutes.
Yeah, sure.
Anna, yeah.
Well, there are always fads, you know, there's always going to be changes, there's always going to be something new, and yes, we do think about that, but I think what this sort of journey that we've been on and we're continuing on really prepares us for is, if people understand that data is important and it's the way to change and evolve, then I think the structure, the people will adapt to, and vice versa. It's very different. I've had the opportunity to visit a couple of stage 7 hospitals around the world, and inserted in different cultures, in different health systems. And I've seen the big ones that, for example, in Holland, where they have EPIC and homegrown systems. There are advantages and disadvantages in both solutions. And so the homegrown solutions, it's much more versatile because you go up to the person and say, I want this works for me, and so just do it. If it's EPIC, obviously it's the top, but I've heard complaints from other colleagues that it takes a long time, and if it's not interesting to them market-wise, then they will be reluctant to adapt something to your specific need. So it's definitely something to consider, something that we've learned, but I think it's a negotiation. In terms of, just to pick up on the other question, we definitely have considered patient, in our specific journey, we've considered how patients perceive this digital transformation. It's very important for us. We had, Vasco spoke about one of our more emblematic projects, which is the HiCare project, and we measure not only in this area, but he's speaking about an inpatient ward, but in other areas as well, ambulatory as well, emergency room, which is always that crucial war-like zone, and we do measure patient satisfaction all over the hospital with every introduction, that technological introduction that we've done. From the very simple things, like, for example, we have dashboards in the emergency room that will tell the patient, we have Manchester triage, so they will tell the blue people, you have to wait an hour, or you have to wait half an hour, whatever. The red ones, the orange ones, and so they have all this information where the doctor is. And we ask them, we have questionnaires to ask them specifically what they think about this. And the HiCare project is the more emblematic example, because it's where the benefit was really obvious for the nurses, especially for the nurses and for the patients. And with not very expensive solutions, you can achieve this. And so, yes, we do, and we continuously monitor this.
Thank you, Anna. Sophie, you're going to have the last word.
I just wanted to come in.
I'll have the last word. But anyway.
I just wanted to come in on that first question, because I think it is a particular problem for the NHS, and I think the reasons for that are the funding and the workforce. I think the sites we heard from were particularly concerned about sustaining their digital efforts, maintaining them, and obviously the more you spend on digital, the more you need to spend to be able to update your systems. And so I think that is a concern in terms of a reality check on what's actually been allocated and what will be made available in the future. And I think there's a really big point about the workforce, where you've got homegrown systems or you've worked with lots of local suppliers like they've done in Portugal. You need quite a big digital team in your hospital to be able to work with those suppliers and create a bespoke solution. And those skills are very, very thin on the ground in the UK generally, but particularly in the NHS. And that's partly because the roles haven't been professionalised, there's a lack of career pathway, and Agenda for Change doesn't help either. So it's a really big problem to know how we're going to be able to update those systems without sort of capacity in the NHS to do that. And I think that the non-clinical digital workforce has been overlooked to date, and it needs sort of quite significant investment and attention quite urgently.
Thank you. So I thought of another joke, by the way. We haven't had many people with jokes. So there are three types of people in the world, those who understand binary and those who don't. So, look, I'd like to, big thanks to Vasco, to Anna, to Sophie, and to Tara. And I think it's now lunchtime. And there's a session, MSD session, at lunchtime for those who want to go. Can we just show our appreciation for our panel and guests? Thanks.